Sir, shall we start?
I'm okay with that, yes.
Nitin, over to you.
Thank you, sir. Good evening, sir.
Good evening.
Dear all, good evening. I am Nitin. On behalf of Mankind Family and Pharma, welcome you all for today's program, that is Managing GERD in COVID-19 patients. So for today's session, Dr. Philip Abraham and with us, and for the evening, Dr. Prashant will be our moderator. So before hand over this session to Dr. Prashant and Dr. Philip Graham, I would like to take few minutes of yours, just a brief introduction about the company. Mankind was established in 1995, founded by Mr. R.C. Juneja, and Mankind is ranked prescription 1 and rank 4 as value-wise. So we are having our strong presence across prescription, drug, OTC, veterinary medicine. So here in Mankind, sir, our philosophy is serving life, which is based on 3 pillars, that is quality medicine, affordability, and availability. So we do have, sir, our strong presence across all the therapy like anti-infective, gastrointestinal, cardiovascular, antidiabetic, nutraceuticals, and many more. So we do have our own R&D center, which is backed up by more than 350 scientists over there. And our main core areas of clinical research and biopharmaceutics are clinical trials, new drug discovery research, biopharmaceutics, and advanced pharmacokinetic modeling and biostatics. With this, sir, I would like to thank all of you for your continuous support, which is encouragement for us. Thank you, everyone. With this, I would like to hand over the session to Dr. Prashant. Dr. Prashant, over to you, please.
Thank you, Nitin. And my apologies for all our audience due to some technical glitches. And I guess this, because this is one of the unfortunate side effect of virtual meeting, definitely would have been not been there in the physical meeting, but we hope definitely very soon we will be having our physical one-to-one interactions also. I hope this corona gets over very soon. So without delaying much, we have Dr. Philip Abraham sir with us, who is consultant gastroenterologist and hepatologist at PD Hinduja Hospital and Hinduja Healthcare Surgical, Mumbai. Dr. Abraham is also retired professor and head Department of Gastroenterology from KEM Hospital, Mumbai. He has been awarded with Lifetime Achievement Awards for contribution to gastroenterology in India by Indian Society of Gastroenterology 2016, for contribution to clinical research in India, Indian Society of Clinical Research 2020. But sir, I'm really very sorry. Sir has been president of Indian Society of Gastroenterology 2002-2003 and Indian Motility and Functional Disease Association 2012 to 2016. He has been editor of Indian Journal of Gastroenterology from 1996 to 2006 and editorial board member of World Journal of Gastroenterology and Journal of Gastroenterology and Hepatology. He is scientific reviewer of World Journal of Gastroenterology, Journal of Gastroenterology and Hepatology, Gut Pathogens, Indian Journal of Gastroenterology, Journal of Association of Physicians of India. He has given many orations and lectureships throughout his career. Just to notify you, the update, the latest ones are Dr. D.N. Amrapurkar sir's oration 2018 and Professor U.K. Sheth oration 2019. Sir has more than 100 publications to his name in various national and international indexed journals. Now I hand over this session to Dr. Philip Abraham, sir. Sir, over to you.
Thank you very much, Prashant. First of all, let me begin by thanking Mankind Pharmaceuticals for giving me this opportunity to address and interact with an audience around the country. Let me clarify here that there is no conflict of interest, and everything that we talk about in the next few minutes will be purely based on scientific information. The mandate given to me is to talk on management of GERD, particularly in the context of COVID. Now, there's a little paradox here in that we've known GERD for centuries, and all of us know in the last 20, 30 years what has happened in the management of GERD and how it has evolved over time. But it's only in the last 1 year that we have experience with COVID, and I hope it ends soon, So our experience with the management of GERD in COVID is obviously restricted to our experience in the last 1 year. So I'm quite sure that no one has a final word on this. I think of this more as a prelude and overview of GERD in COVID so that we can interact with our participants from around the country and share our experiences, because no one around this country, or for that matter around the world, can say that they have the final word on GERD management in COVID. So if you'll give me a second, let me see if I can share my slides with you. All right, are the slides visible now? Okay, so that's a mandate given to me that we talk about GERD management in COVID. And as I clarified, the experience is limited. So I'll spend a few minutes in giving an overview of what is GERD, something that's known to all of us, but particularly focusing on the pathophysiology and a brief outline of the management, only so that we can set the context for its management in COVID. So those of us who are familiar with the basics of gastroenterology and who have had some interest in GERD know that ultimately GERD is an imbalance in forces. We know that acid and pepsin are the offensive factors in all acid peptic disorders, but what protects the esophagus? Right through the day, a normal individual has reflux state happening all the time, but we never sense it. And just a small fraction of individuals will ever develop GERD, that is symptoms from gastroesophageal reflux or disease, endoscopic or histological manifestations of reflux disease. So obviously there is a full array of defensive factors that protect the esophagus from normal refluxate. And we divide that at 3 levels. One is, and probably the most important, is the esophagogastric junction, which has several components to it. If that is crossed, or if that is overcome, we have esophageal injury that results. And what are the protective factors within the esophageal mucosa that protect it? And if that too is breached, we have a third level of defense, and that is the
Hi, sir.
Yeah. I don't know if something wrong with the connectivity here.
Okay.
I can do that now. Can I resume where I was?
Yes, sure, sir.
Yeah,
Sir, just
yeah.
reshare the screen. Yes, sir.
Yes. Can you get the screen now?
Right, sir. It is.
All right. Yeah. Okay. I'm sorry about these glitches. Like we said, technology really has a way of troubling us when we least want it to. So we were talking about the various levels of barrier against reflux and the damage that it can cause. So we just take these one by one and brief before we go on to the management of GERD. We'll take the first one, that is esophagogastric junction, and what are the components. You can see that the GE junction is really primarily composed of a mechanical barrier. We have the lower esophageal sphincter, which is also referred to as the internal sphincter, and we have the crural diaphragm, which is referred to as the external sphincter. I'm not going into details of anatomy here, but this is probably the mechanical component of the GE junction is probably the most important barrier against reflux disease. So if you look at this diagram here, we can see the internal sphincter, that is the esophageal circular muscles, as you can see them here, and the external sphincter or the crural postal part of the crural part of the diaphragm. These between them form the major component of anti-reflux prevention. Then we have this, and what helps to overcome this is what we'll have to look at. In principle, the most important component of GERD is what we call the transient lower esophageal sphincter relaxations. This is like a vent for a pressure cooker. When the pressure within the stomach increases, the vent opens up and air escapes from the stomach. So this is actually an escape mechanism for the air in the stomach as we get in burps or belches, for example. But in patients with reflux disease, the primary disorder is an increase in what we call TLESR. TLESR is relaxation of the EG junction inappropriately. That means not in response to swallowing. This is a relaxation that occurs spontaneously, and that probably is the most common or most important component after the barrier is overcome of reflux happening. So here we can see it. This is an impedance manometry tracing. You can see that the LES opens up spontaneously, not in response to a swallow. It opens up spontaneously to act as a vent for air or fluid to escape from this stomach into the esophagus. So primarily, like I said earlier, it is TLESR that is a major component of reflux. What is the role of the other factors that contribute to reflux? Hiatal hernia. Does everybody with hiatal hernia have reflux? No. Does everybody with reflux have hiatal hernia? The answer is no. Hiatal hernia is primarily also a dynamic entity. Those of us who do endoscopy know that during endoscopy, because of retching, there is a false impression of a hiatal hernia. And many of the endoscopy reports that we see reporting hiatal hernia are actually erroneous because this is a dynamic entity. But in those who do have a hiatal hernia, the herniated part of the stomach actually acts as a reservoir from which acid could now reflux freely into the esophagus. So when the hernia actually goes above the diaphragm, that acts as a reservoir from which refluxate occurs into the esophagus. So you don't need hiatal hernia for causing reflux. Not everybody with hiatal hernia has reflux, but when it is there, it's an important component of GERD. This is a concept that I want to introduce now, what's called the acid pocket. We just talked about acid being held in a reservoir in the hiatal hernia. But what we have realized in the last few years is that there's something called an acid pocket. And I'll show you that in a diagram in the next slide. Acid pocket is a reservoir of acid that remains above food. After a meal, there is an amount of acid that remains above food, keeping the pH in that region low, and from there refluxing up into the esophagus. I'll show that in the next slide. You can see here that this is a patient who's at rest, but following meal, the postprandial period, where normally the EGJ junction pH is high and the esophagus remains high, and this is the normal stomach pH, we realize that after a meal, the stomach pH goes up. But closer to the EGJ junction, there is an acid pocket where the stomach pH remains low. That is what we call an acid pocket, and that is now recognized as an important component of reflux disease. So we talked about the GE junction, the mechanical part of it. We talked about the hiatal hernia, the TLESR, and the acid pocket. And then we have the pressure gradient between the stomach and the esophagus. You know that the stomach pressure is usually higher than that in the esophagus, and gastric emptying or gastric dysmotility is taken as an important component of reflux disease. Unfortunately, over time, we've not been able to show a straight relationship between gastric pressures and GERD. So today, the role of prokinetics, for example, in the management of GERD has taken a backseat because gastric dysmotility or delayed gastric emptying is not a major component of GERD. So like the last sentence says there, impaired gastric emptying may not be a major factor, but in clinical practice, of course, we can recognize those who have a delayed gastric emptying. So these are the components of gastric reflux after the mechanical barrier has been overcome. Then we have the esophageal clearance. Every time refluxate gets into the esophagus, there is saliva that goes down and neutralizes the acid, because saliva, as we know, is alkaline, and repeated swallowing also manages to get rid of the acid that is refluxed into the esophagus. So esophageal clearance is getting rid of the acid that has now refluxed into the esophagus. The second part of this is the esophageal injury. What are the defense factors we have at the esophageal mucosa level? And there again, the defense factors are divided into pre-epithelial, epithelial, and post-epithelial. I've mentioned about the secreted buffers in saliva and mucosa. Unfortunately, the refluxate usually has more acid in it than saliva and mucus can neutralize. So that does get in and reduces the pH within the esophagus. Then we have the apical cell membrane and the tight junctions between the cells of the esophageal mucosa that prevent diffusion through the mucosa into the bloodstream. And finally, post-epithelial, the rich capillary blood supply to the esophagus gets rid of any acid that is refluxed into the esophagus. So we have the pre-epithelial, epithelial, and post-epithelial microscopic barriers also against reflux. The last one is perception of reflux contents. If everybody has acid going into the esophagus, why is it that some people have symptoms, some have excessive symptoms, and some have no symptoms? So obviously the third component is the neurological component of GERD, or what we call peripheral sensitization and central sensitization. So only about 10% of reflux episodes are actually accompanied by symptoms. And there are various channels through which this perception occurs. But what is very important for us is that the intensity of damage to the esophagus does not correlate to the symptom intensity. In other words, even in a normal esophagus, where there's no damage whatsoever to the mucosa or the otherwise, a person can have severe symptoms. So there is no correlation with microscopic or endoscopic damage with the severity of symptoms. So there is a role for perception of reflux that also accounts for why some people have reflux symptoms and why some others don't have. So perception of reflux, there is a condition called non-erosive reflux disease. That's again an entity that we need to remember every time we talk about GERD. GERD is symptoms and or endoscopic or microscopic damage. NERD is where there is no endoscopic damage. But paradoxically, the ones who may not have endoscopic damage are the ones who may have more severe symptoms. So that is where the neurological component of GERD perception comes in. So I want to bring in this entity of NERD and divide that into the various types called type 1, type 2, type 3. In all of them, symptoms are typical. In type 1, acid exposure is also abnormal. So you have correlation of symptoms with the acid exposure, and these patients will respond to PPI. This is the standard NERD that we see in clinical practice, where an endoscopy is normal, but they have abnormal exposure, they have symptom correlation, and they respond to PPI. The second type is, again, they have typical symptoms. Acid exposure, on the other hand, is normal. That means there is no abnormal exposure, they have a correlation of symptoms with acid exposure, and they do have response to PPI. That means the amount of acid going through is not abnormal, but even if you suppress that amount of acid, they are relieved of their symptoms. The third type is what we call functional heartburn, where normal amounts of acid go into the esophagus. There is no correlation of the amount of acid exposure and the symptoms. Some of them will respond to PPI, the others will not respond to PPI. So there are two entities of hypersensitive esophagus, one that correlates with symptoms and acid exposure, the other that does not, that is called functional heartburn. So we have GERD, we have NERD, and in NERD, there are two parts that we need to remember, those who have the hypersensitive esophagus and those who have functional heartburn. How do we investigate patients with NERD or GERD? Obviously, the most reliable parameter we have is the pH monitoring, and we have ambulatory pH recorders in every major center around the country. And the best single determinant is the amount of time that the acid is there in the esophagus, the total 24-hour acid exposure time in the supine position as well as in the upright position. Then, of course, we analyze the number of reflux episodes, the duration of the episodes that last more than 4 or 5 minutes, and what we call the symptom index, correlation of drop in pH with symptoms. Overall, there's something called the Demister score that is now automatically generated on all these computerized ambulatory machines, which give a high Demister score in those who have true reflux. So the diagnosis of GERD primarily is based on documentation of acid in the esophagus and correlation of symptoms with the acidity, irrespective of what the endoscopy shows. So that's an impedance manometry. We obviously don't do it in every patient with GERD, but it's particularly important in those who we plan for surgery. And you can see this is what a normal esophagus peristalsis looks like. But based on this, an impedance can tell us that what is refluxing up is only air or liquid or a solid bolus, and whether it's moving up or down. So manometry gives us pressures, and impedance tells us what are the types of refluxates that are there in the esophagus. Endoscopically, we grade the damage as grade A to grade D, and grade C, fortunately, are not very common in India. They're quite common in the West, but fortunately for us, most of them have either NERD, that means non-erosive reflux disease, or just mild changes like grade A or grade B changes. In the rest of them, I mean, in a majority, these are the only two kinds of changes that we get. Fortunately, we don't see grade C and grade D so frequently in India. Which brings us to the last part of our review of GERD before we go into management of GERD in COVID. Why did we spend time in discussing this? Because unless we know this part of it in detail, we won't be able to say how management of GERD in COVID is different from in day-to-day life. Just as a revision, we have all heard of the lifestyle modifications that we need to do in GERD. Now, with the availability of excellent drugs in the last 2 decades, much of this has taken a backseat. But the fact remains that these are important components of the management of GERD. In the overweight, weight loss, smoking cessation. If somebody asked me whether I can continue to have alcohol or smoke, I would say you can take alcohol in moderation, but there is no moderation for tobacco use. Every single puff of cigarette smoke, every little amount of tobacco a person consumes is bad for GERD. So there is no threshold. Smoking has to be cessed, or it has to be ceased completely. Avoid large meals. Never eat till your stomach is full. Always leave some place there. Avoid fatty and spicy foods. All of us know that if we have a heavy biryani yesterday, we'd have the taste coming up even today. Tea, coffee, carbonated or caffeinated beverages to be restricted. Carbonated beverages we can do without, but tea and coffee are part of their day-to-day life. So we restrict them to 2 cups a day, one with breakfast and one at tea time. Late night meals. Ideally, you should wait for at least 2 or 3 hours between a meal and bedtime. These sounds like very simple principles, but when we tell it to our patients, we realize how often they violate these mild principles of that. Elevating the head end of the bed by 20 centimeters is not a very practical option, especially in those who wear light clothes at night. They tend to slip down in the bed if we elevate it. Remember, elevating the head end of the bed is not the same as putting two pillows. We're not talking about elevating the head. We're talking about elevating the head end of the bed. But that's not very convenient. Most individuals are controlled by taking care of the other lifestyle management and lifestyle modifications, and also the medications that we have for GERD. The core of management for GERD is acid suppressant therapy. In our hospital, for example, the most common PPI used is pantoprazole. The drug has stood the test of time, excellent drug, no side effects, virtually no drug interactions. So a host of acid suppressant therapy is available to us in India. The one we use most commonly in our institution is pantoprazole, but you know that there are second generation PPI as well, and all of them are equipotent in similar dosings. Okay? So for GERD, unlike for what we call garden variety duodenal ulcer, the duration of therapy is 8 weeks. For healing a duodenal ulcer, we need only 4 weeks. But for healing a gastric ulcer or GERD, we need an 8-week course. Extremely important is what I have underlined here, that there is no evidence to show that twice a day dosing or double dosing is better than single dosing once in the morning before breakfast. For example, pantoprazole 40 milligrams in the morning before breakfast is good enough to heal GERD. It's only in the extreme cases where nighttime reflux is an important component that we think of splitting the dose or adding a nightcap. But in a majority, one drug in the morning is good enough for us to say that this patient has responded to this acid suppressant drug. For patients who have only partial response, you may then have to tailor the therapy. And in those who have a nighttime symptom, nocturnal heartburn as a disabling feature, there you may add on what's called a nightcap. That means a morning PPI and an evening H2RA. One more principle that we need to know is that H2RA are not the preferred drugs for GERD anymore. So ranitidine, famotidine, for example, which we have in India, are not now recommended as first-line treatment for GERD. They may be used as a nightcap and add on to a morning pantoprazole, for example, or a morning PPI. If there's nighttime symptoms, you add on a H2RA. The drawback about H2RA is histamine H2 receptor antagonist. The drawback is that they don't give the kind of 24-hour control in acid secretion or pH above 4 that you need to heal GERD. So they're usually used as an add-on. The other problem that they have is that there is tachyphylaxis. When you use an H2RA for a long time, even for a few weeks, the effect actually wanes off, and you have to have a drug holiday before you can reintroduce the drug. So ranitidine, famotidine, not commonly used for GERD management, not the first line of recommendation for treatment of GERD, but can be used as a nightcap. Antacids are used as an adjuvant on demand because they give excellent immediate response, but for obvious reasons cannot be used for the long term. In those in whom clinically we suspect that gastric motility is playing a component, you can add on a prokinetic drug. Although there is evidence from the 1990s to say that prokinetic drugs also can take care of GERD in up to 70%, when we have PPI that will heal it in more than 90%, it's obviously not the first line drug. So you may add on a prokinetic as a temporary measure where you clinically suspect that these patients have gastric dysmotility as well. Finally, surgical and endoscopic measures. There are recommendations. In fact, just last year, there was a group of surgeons and endoscopists who met together and gave recommendations about in which patient would you consider a surgical option, which patient would you consider an endoscopic option. In those who are PPI responders, that means well controlled on PPI. If the patient is comfortable with it, the first line of recommendation is continue the PPI. On the other hand, if the patient wants that he doesn't want to continue the PPI for a long time, although he responded to PPI, we could consider laparoscopic fundoplication or magnetic sphincter augmentation. In those who do not have a hiatal hernia, an endoscopic measure, what's called the transoral incisional or incisionless fundoplication is a third option. So these are those in whom PPI has given good response. On the other hand, we have patients with GERD who have not responded to PPI. Then a lap fundoplication where there is a large hiatal hernia, MSA, that's magnetic sphincter augmentation in those who have predominant regurgitation, regardless of whether they have a hiatal hernia or not, and transoral incisionless fundoplication when there is no clinically significant hiatal hernia. In patients who have impedance pH study negative, no surgical recommendation is available right now. So surgical recommendation or surgical intervention and endoscopic intervention, there are specific groups based on whether they are PPI responders or non-responders, whether they have hiatal hernia or not, and whether the patient prefers to continue PPI or would rather consider an option. So there are components that go into decision-making about which patient goes for endoscopic or surgical management. Because we have such a disciplined approach to that, in our center, for example, at Hinduja Hospital, very rarely do we send patients for endoscopic or surgical therapy, although we have well-qualified well-qualified, competent endoscopists and surgeons who can do the job for us. So these are very restricted patients in whom the patient makes a decision along with the physician based on available other information. So with that, we have finished our overview of GERD, its pathophysiology and management. Now we come to our topic, which will not take us very long because all we talk about is what is special about GERD in COVID. We know that PPI is the first line treatment. We know about add-on therapy. We know about the endoscopic and surgical options, but what's special about COVID and what do we need to consider about GERD? And here we have to stand some of our principles on the head. On one side, we said that PPI is a drug of choice for GERD. On the other hand, we have evidence that PPI may be counterproductive in COVID infections. So where do we draw the line? How do we balance these two competing or conflicting viewpoints or problems that are there in a patient with GERD with COVID? So let's look at some facts about COVID that's relevant for us now. We all know that SARS-CoV-2 uses the ACE2 enzyme, that is the angiotensin converting enzyme 2, and importantly, what's called the transmembrane protease serine 2. It uses these receptors to invade host cells. Now, although all of us know about the respiratory complications or manifestations of COVID, what we must remember is that these receptors are not restricted to the lung. They're found in almost every organ of the body, importantly, the GI tract as well. So the GI tract may be an entry point and a reservoir for COVID. So we as gastroenterologists have patients who present with nausea, vomiting, importantly with acid reflux, diarrhea, abdominal pain, which may be part of their entire presentation or may even be the sole presentation. So we as gastroenterologists have patients who come to us with COVID with only GI symptoms. And the explanation is straightforward. It is because these receptors are found in the GI tract as well. So once a virus enters the GI tract, it can alter the gut microbiota. And there could be a reduction in the beneficial commensals or in the community richness or what we call microbial diversity. And we know that these are important components of GI defense. So we have a virus that can enter through the GI tract. We have a virus that can make manifestations only in the GI tract. And we have a virus that can alter the microbiota of the GI tract. So let's look at the other side of it. What does the microbiota do at all? All of us know that in ventilated patients or in patients who are immune compromised, we are very selective about using PPIs because acid and pepsin are the first line of defense against invading pathogens. We are constantly exposed to pathogens in our environment. Our food is never sterile. It is the acid and pepsin that protects us against invasion by pathogens. Now, because PPI have been so safe with 20 or 30 years of use, there is a tendency to overuse it. Like if one tablet in the day works good, 2 tablets would work better. That's a principle that many practitioners follow. But we must remember that this is a double-edged weapon. If we get rid of the acid completely from the stomach, we're actually reducing the action of pepsin and we're exposing ourselves to pathogens, which may not matter if we have our immune system intact. But in patients who are on a ventilator, who have ventilator-associated pneumonia, if we take this first line of defense away, they can have ascending infections from the GI tract into the throat and then into the lungs. So we have done studies to show that the pathogen that you isolate from the gastric juice is the same one that is causing the pneumonia. So maintaining gastric acid integrity is extremely important in patients with viral infection. Secondly, the gut microbiota. It's an important and essential component of defense against invading pathogens. The gut and its microbiota together form the largest immune organ in the human body. We think of immunity as humoral and cellular. We think of all the circulating cells in the bloodstream. But remember that the largest reservoir of immune cells is in the stomach, is in the GI tract. So the GI tract is actually the body's largest immune organ. And modification of the microbiota can affect the immunity not only of the gut, but of distant organs as well. So in the context of COVID, alteration of the gut microbiota can, in fact, reduce the immunity in the lung. So the gut microbiota integrity is extremely important for preventing even lung infection. So what we call the gut-lung axis. So on one side, we say that the virus can alter the microbiota. On the other side, we say that if the microbiota is altered, you can change the immunity in the gut as well as in the lung. So that's what it says. COVID affects microbiota. Altered microbiota also predisposes to COVID infection. Extremely important to maintain the gut integrity. What do we really do in the management of COVID? Viral infection can alter, as we said earlier. We tend to administer antibiotics indiscreetly to patients with COVID infection, although there is absolutely no evidence that doxycycline, or for that matter, even ivermectin or azithromycin or amoxicillin clavulinate, whether any of this can do anything for COVID. But antibiotics are indiscriminately used or prescribed in COVID infection. Antibiotics can change the gut flora. Anti-inflammatory agents can change the gut flora. Steroids, we're all aware that it can change the gut flora. But in the context of our discussion today, we're talking about acid suppression drugs. If we take the first level of defense away, we can change the gut microflora and so change the pattern of COVID infections, something that we don't realize so frequently when we talk about the use of acid suppressions in viral infections. All of us know that PPI are the most commonly co-prescribed drugs in the world today. Their sales figures exceed that of any other drug. And there are data to show that up to 2 out of 3 patients who are prescribed PPI for the long term really don't need PPI. In COVID, then, it's very important for us to be very discriminatory when it comes to prescribing a PPI. What does it mean? Can we not use a PPI to treat GERD in COVID? No, it doesn't say that. It only says use the drug discreetly. So we have data just last year to say that there's an increased risk of COVID-19 among users of proton pump inhibitors. Not only is the frequency more, but the other article at the bottom says that the severity also is more in those who have used a PPI for GERD or any other indication when the person has COVID infection. I'll come to clarifications a little later. It's not only PPI. If we are talking about acid suppression, obviously an H2RE should do the same thing. So there are studies that says even famotidine can do the same thing. By suppressing acid secretion, you can predispose to COVID infection, or you can increase the severity of co-infection. Now, there's something paradoxical about famotidine because of its action on the protease and receptors of the body. Famotidine was used, most of us won't know this, was actually tried out as an antiviral drug against HIV in the 1990s. And even today, there are trials of famotidine with hydroxychloroquine in the treatment of COVID. So on one side, we say that suppression by famotidine can increase the chances of COVID. It can increase the severity of COVID. On the other side, we're talking about using famotidine as an antiviral agent. So that's a paradox of using famotidine in the treatment of GERD. But whatever we have as molecular level studies or as in vitro studies have not been translated into clinical studies. So we're obviously not anywhere near using famotidine for the treatment of COVID, although there are trials going ahead with that. But what we need to remember, in principle, is that acid suppression can be dangerous, increasing frequency, increasing severity in those exposed to COVID. Does it really matter? Is GERD so common in patients with COVID? And the next slide says that. On the other hand, the likelihood of GERD increases predisposition to COVID infection. Laryngopharyngeal reflux, where the acid in the throat actually drops, makes these individuals more prone to COVID infection. So on one side, we're saying acid suppression makes them more prone. On the other side, we're saying if we don't treat the GERD, it makes them more prone to COVID infection. So where do we draw the line? We draw the line by saying, let's be responsible in the prescription of acid suppressant drugs in COVID. So as I said earlier, especially laryngoesophageal reflux may increase the susceptibility to COVID infection. PPI remains the standard of treatment for GERD. Like I said earlier, pantoprazole and the other PPI do remain the first line treatment for GERD. But we must remember that acid suppression can increase the risk of COVID and the likelihood of severe outcomes of COVID-19. Where do we draw the line? We draw the line by saying, be discreet. The more profound the acid suppression, the greater the risk. So a double dose PPI, which we talked about earlier, is definitely not on when we're treating COVID, when we're treating GERD in COVID. Go back to the primary principle where we use PPI as a single dose. Pantoprazole 40 milligrams in the morning can heal GERD. Remember that as a principle. Don't overdo the acid suppression. So what we should do is be discreet, use the lowest effective dose for the shortest effective duration, because the benefit outweighs the risk when we actually use these drugs discreetly. So that brings us to the end of the presentation. My point is, we know that the management of GERD requires PPI and requires that we use PPI discreetly, particularly so in COVID-19 infection. Be very careful about the amount of acid suppression you want to introduce, the number of drugs that you want to use that can break the acid barrier. Use PPI, use them discreetly, use them in the way that they were meant to do. Once a day is enough. Pantoprazole 40 milligrams or the other drugs in equipotent doses is enough to treat GERD and does not significantly increase. It's only the double dose PPI that truly increases the predisposition to COVID infection. So if I have to go back to my slides, can I discontinue my slides here? Let me see if I can do that. Okay, so with that, I come to the end of my presentation. I'm open to questions if you have any. I could switch off my slides. I stop sharing the slides and we'll get back to questions. More than questions, is going to be an interactive session because I'm willing to learn from our participants who probably have seen many more COVID patients than I have. Thank you again, Dr. Agarwal.
Thank you, sir. Thank you so much. I know, sir, there were some technical glitches, but after that, sir, you beautifully actually covered whole of the GERD management. And of course, why this GERD and COVID, that basically gut and lung axis, which you shared, sir. So that is definitely something which definitely might be new to our audience also, sir. So thank you so much. Sir, with your permission, sir, we have few questions. So, sir, can we take it?
Sure, we can. But before we go into that, may I offer my profound apologies to all those who are listening in for all the technical glitches. Sure, we can take the questions.
Sir, no issue, sir. I mean, these are the technical glitches. I mean, that is why these are the glitches. So that can happen. That is, I mean, nothing. Nothing under our control, sir. So thank you, sir.
A machine that was working beautifully till last night gave way when we needed it this morning. Anyway, sorry.
Sure, sir. No issue, sir. So the first question is related to Ecosprin, because nowadays Ecosprin is also prescribed, I mean, along with the other COVID-19 drugs. So is there any relationship Ecosprin and PPIs, and how long, I mean, PPIs can be given along with Ecosprin?
Okay. So Ecosprin acts not only by stimulating acid. We all know that Ecosprin can increase acid, but Ecosprin acts mainly by destroying the barriers. So if we have adequate acid and adequate defense mechanisms, we really don't need an anti-acid drug to be co-prescribed with ecosprin. The precaution we have to take when we use aspirin, ecosprin is a trade name, as you know. When we use aspirin, the precaution we should take is always to have it after a meal, because the pH is anyway going to be high at that time. So aspirin does not do significant damage. If the person, on the other hand, has a pre-existing acid peptic disease, then you need to cover it with an anti-acid drug. So for a patient who's had an ulcer in the past or who has GERD, we must always cover ecosprin with PPI. And as long as the aspirin is there, the PPI is required in the lowest dose. For example, 20 milligrams of pantoprazole, 20 milligrams of esomeprazole in the lowest dose.
Thank you, sir. Sir, the next question in general patient, I mean, for how long we can prescribe PPIs to our patients?
Okay, so one of my students, I wish he were here, has done a study on the safety of PPI for the long term. There are enough data that are coming from around the world saying that any drug used indiscreetly can have side effects. PPI are beautiful drugs, among the most safe drugs on earth, but you can't overuse anything that is safe. You can't drink too much water, you can't hyperventilate, it's bad for you. Too much air, too much water is also bad for you. So a PPI should be used to the extent that is useful for the patient. When we have warnings, the US FDA for some time ago had issued a black box warning about the use of PPI. Then they took it off. And ultimately now they're saying is in those who have risk factors, the very old, those who have brittle bones, those who have pre-existing kidney disease, in these individuals, if you need to use a PPI, please go ahead and use it. They haven't said it's contraindicated, but always follow the principle of least dose or the lowest dose for the shortest effective duration. So in no individual is PPI contraindicated. In every individual, if we use it in the lowest dose, it's safe. But in those who have brittle bones, who are elderly, in bed all the time, have pre-existing kidney disease, you would be more careful about using the drug. Otherwise, there is no harm in using it safely.
Thank you, sir. Sir, the next question is, they want to take advice on PPIs in the morning and a prokinetic before dinner in the night.
Okay, we don't have many studies for this. It seems like a logical combination in those who have nocturnal regurgitation. You know, many patients who have been given a PPI in the morning in adequate doses wake up in the night with regurgitation. And one of the drugs that we use in such a situation is an antacid with alginate. But you know that that combination alginate has a function of retaining sodium. So we don't use it in patients with cardiac disease or for the long term. So alginate is a very useful rescue medication if you use it sporadically. Otherwise, the next line of recommendation, international guidelines are to use an H2RA, because if you suppress the acid, refluxate causing regurgitation that is non-acidic at night is quite unusual. If you suppress the acid, why are we paying so much attention to night? For one thing, we are asleep at night. The other thing is night is a period, the longest duration during which there's no food going into the stomach. So there's no neutralization of acid in the stomach during the night, which is why symptoms tend to occur more at night. So adding a nightcap in addition to a morning PPI is all we need. Prokinetics, if there is free regurgitation of what we call volume regurgitation, the patient actually wakes up with fluid in his throat or the mouth. At that time, we could use a prokinetic. Again, one point to remember is prokinetics do not work on the esophagus. They do not help esophageal clearance. They work only by gastric emptying. So if you can clinically analyze and say that this person has delayed gastric emptying or gastric dysmotility, that's the one place where prokinetics come in useful.
Thank you, sir. Sir, next question is actually related to COVID only. Nowadays, like we have seen, there are many videos on YouTube, and many doctors have also suggested about the prone ventilation. So, does prone ventilation also increases acidity?
Acid reflux, yes, it does. It does, yes. In fact, even position left side and right side also individuals have differences in reflux. But prone ventilation, of course, when patients are on prone ventilation, except those ones who try it at home as part of their well-being, almost all the others are in hospital and they're being ventilated. So these patients are almost always, in fact, I would say always, on a takes care of the acid reflux. It doesn't take care of the volume reflux. But yes, the fact is that it does increase reflux.
Thank you, sir. Thank you so much, sir. Sir, so just once again, I mean, because people are again asking about acid suppression during COVID-19. So, sir, although you have beautifully summarized it, sir, can you just in one or two line, I mean, again, can you give it? I mean, there are actually plenty of questions, so they might have not heard, or I don't know, sir.
All right. Or maybe I put them off by switching off the technical part of it. Okay, I'll just summarize in 2 or 3 lines. The presence of GERD predisposes to COVID, especially when there is laryngopharyngeal reflux. The treatment of GERD, including NERD, is PPI. The discrete treatment of GERD, irrespective of COVID or not COVID, is 1 tablet in the morning of one of the PPIs. Indiscrete is when you use it more than once a day, which a lot of our colleagues do. Unfortunately, if you go overboard with acid suppression, the risk of frequency of COVID and severity of COVID goes up. So reflux can predispose to COVID infection because of acid in the throat, reducing local immunity. Treating reflux is important, but treating it discreetly is more important because over-treatment also increases COVID. I hope that summarizes everything.
Thank you, sir. Thank you so much, sir. And with this, we are approaching our time also. So thank you, sir, for this wonderful presentation, and sir, wonderfully explaining about GRD management. And definitely, I mean, this is one aspect, I mean, in a vast gastroenterology. So definitely in the future also, we will take up more subjects, more topics under the umbrella of gastroenterology. So for now, sir, thank you, sir. And now I
Thank you
invite
so
Mr.
much.
Vishanena from our marketing team to say the thank you note.
Thank you once again.
Ravisha?
Yes, sir. Thank you,
Over
Dr.
to you.
Prashant. As we have come to an end of the session, I would like to thank our eminent speaker for enlightening us about management of GERD in COVID-19 and also sparing his valuable time with us. So thanks a lot, sir. Last but not the least, I would like to thank each and every one of you who has joined us today and has made this learning initiative a success. So thank you all once again, and wishing you a great day ahead. Be safe and stay at home. Thank you so much.
Thank you, sir.
Thank you.
Thank you
Thank you
all.
so much.
Thank you.
Thank you.